I have no financial relationships or conflicts of interest to disclose for our presentation today. Air pollution is a pervasive problem in many parts of the world. It's been shown that the global south has higher levels of air pollution and disproportionately bears the disease burden of air pollution. This is shown in our map to the right from the World Health Organization. It's a graphic representation of particulate matter concentrations across the world. And we see that in general, the global south tends to have higher concentrations of particulate matter or air pollution, as represented by these darker green colors. One of these regions with higher air pollution levels is sub-Saharan Africa, which is where our study takes place. Sub-Saharan Africa consistently has higher levels of particulate matter than is recommended. Ambient air pollution is a term that refers to outdoor air pollution. It has been associated with negative health outcomes, such as respiratory disease and cardiovascular disease, and mortality in general. Specifically, fine particulate matter less than 2.5 microns, also commonly referred to as PM2.5, have been linked to cardiovascular disease and mortality. We know that based on previous studies, despite successful viral suppression on ART, adults with HIV still have a higher risk of cardiovascular disease. Despite the increased levels of air pollution in sub-Saharan Africa and the known harmful health effects of air pollution, the data on adolescents in this area is limited. This leads us to our objective, to investigate the relationship between ambient air pollution and subclinical vascular disease in youth living with and without perinatally acquired HIV in urban Uganda. We sought to study this through a prospective observational cohort study based at the Joint Clinical Research Center in Kampala, Uganda. There was a total of 69 participants that were included in our analyses. 38 participants were living with perinatally acquired HIV, and 31 of them lived without HIV. Both groups had measurements at baseline that at 96 weeks, approximately 2 years later. Our study group included 38 participants of adolescents that had perinatally acquired HIV. They were all on antiretroviral therapy with their HIV RNA levels less than 400 copies per milliliter. They did not have any active co-infections through the duration of the study, and they live in and around Kampala, Uganda. Our control group, on the other hand, did not have HIV or HIV exposures. They also did not have any other infections, and they lived in and around Kampala, Uganda. Measurements of subclinical vascular disease were our main outcomes of interest. And we measure this through pulse wave velocity and intermediate thickness. All participants' vascular health was monitored using these measures. Pulse wave velocity is a measure of arterial stiffness, and this was measured by tonometry of the carotid and femoral arteries. The stiffer the arteries are, also known as the higher pulse wave velocity is, there is a higher risk of developing vascular disease in the future. Intermediate thickness is a known measure of atherosclerosis, and this was measured using beam-mode ultrasound scan of the carotid arteries in our study. As vascular disease measures were our primary outcomes of interest, air pollution was our primary exposure of interest. This was measured in levels of PM2.5 from a beta attenuation monitor that was located at Makerere University School of Public Health in Kampala. So the PM2.5 was averaged throughout the years, and we used those readings. Secondarily, we also looked at socioeconomic status, as we know that SES is tightly linked with air pollution exposures. So our other secondary exposure of interest was SES. Socioeconomic status was scored using a questionnaire that were adapted from the World Health Organization as well as a survey from USAID. These surveys assessed living standards in the home, such as water and electricity access, but it also assessed the education level and work of the head of the household, the income levels, and food insecurity. First, in our analyses, we studied the baseline characteristics of all of our participants in both the PHIV and the control groups. Their ages were similar at baseline, at around 12 years old at the start of the study. There was more female participants in our study group, and while the SES score was similar, the PHIV group was slightly more likely to be energy poor. So the SES score, as a reminder, as mentioned before, was derived from that questionnaire, the surveys that we gave to the parents or the caretakers of our participants. And as we mentioned before, both groups' vascular health was monitored over a period of 2 years. There were no significant differences between the pulse wave velocity between the two groups, nor between the two time points. Intima media thickness, it was thicker at baseline for our PHIV group. However, their trajectory over time improved for the PHIV or stabilized, and worsened for the control over the 2 years. So we saw actually an increase in intima media thickness in our control group. The average yearly PM2.5 levels increased significantly from the baseline. The levels went from what is considered moderate of health concern as defined by the WHO to a range that is considered unhealthy for sensitive individuals. Then we ran separate regression models to study associations between the change in PM2.5 and the change in IMT. Highlighted here are two of these models. The first, we saw that the change in yearly PM2.5 had an independent positive association with changes in IMT over the last 2 years. This was after controlling for other confounding variables, such as demographic factors, age and sex, as well as their HIV status. Also interesting to note in this model, being female seemed to be protective. And on the second model, we also included the SES score and inflammatory biomarkers. These inflammatory biomarkers were associated with changes in IMT in univariate analyses, and they were included in this multivariate analyses after that. In this model, we still saw that there was no association with HIV status and changes in IMT. However, there was significant association between change in yearly PM2.5 and change in IMT again, even after controlling for these multiple variables. Similar models were also ran for pulse wave velocity changes. However, there was no significant association between air pollution and those measures.
In conclusion, we saw a rise in ambient air pollution over the 2-year study period in the greater Kampala area. Subclinical vascular disease, as gauged by increased intima media thickness, was positively associated with increased air pollution levels in both our study and cohort groups. These findings suggest that all youth, with or without HIV, might be susceptible to downstream health effects of worsening air pollution. The demonstrated increase in cardiovascular disease risk re-emphasizes the need for further studies. Most importantly, it emphasizes the urgent need for air pollution control. Our findings have wide implications beyond Uganda and beyond HIV studies, across the Global South, because we know that other areas of the Global South tends to have high PM2.5, and because we know that the average population age in these areas is younger. Also, given the geographical overlap between the highest rates of perinatally acquired HIV and high rates of air pollution, we hope to continue to gather knowledge that will improve the health outcomes of those growing up with PHIV. Thank you to Joint Clinical Research Center of Kampala and University Hospitals of Cleveland for making this study possible.